two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 92. And today I'm joined by my co-host, Dr. Jose Checo. Welcome, Dr. Checo.
Hi, Swapnil. Good evening. How are you?
I'm good, thank you. How's things going in India at the moment?
Things are pretty calm at the moment. The number of new cases have come down to very low levels, almost to the baseline level before Omicron. So we are doing well, I must say.
Yeah, it seems like the Omicron wave is tapping everywhere now. So looks like we probably will get some breather in most parts of the world now. Now, the topic that we have chosen today is, again, COVID related. Having said that, this is one of the important controversy that was raised during the pandemic, especially the second wave. And the data available was quite conflicting at that time. And the trial, which was recently published in JAMA, called as Recovery RS trial. Now, this trial was published off print in last year in August. Having said that, the full manuscript is available and the detailed statistical analysis is now available along with all the primary and secondary outcomes. So it's worth discussing about this controversy because the evidence on this topic is quite fascinating, to be honest. And just to give a bit of context around this topic is, obviously, as we all know, COVID-19 was quite a challenging pandemic for most parts of the world. It has questioned a lot of the myths around the treatment of respiratory failure, particularly ARDS, that before COVID, we never used to use steroids in ARDS, but obviously with recovery trial, we started using steroids in COVID. Also, the research during this pandemic has been quite fascinating because we came up with quite large number of multi-center adaptive trials in a very short period of time with a very robust statistical analysis. So this pandemic has shown us some of the positive sides in the research world. Now, having said that, one of the controversies that still remained addressed was around the oxygen therapy in COVID-19. And obviously, you witnessed quite a lot of oxygen shortage during the pandemic in India. And the issue was how to prescribe oxygen therapy in these patients. And various parts of the world chose different strategies. Some parts did perform high flow oxygen therapy. Some decided to use NIV as the ICUs were getting full because intubating every single patient was becoming impossible. And I guess that led to key questions that needed to be answered during this pandemic, whether we should perform early versus late intubation. If we need to perform the late intubation, then how late we can wait. And in meantime, what oxygen therapy we should use. Should we stick to the standard oxygen therapy? Should we use high flow? Should we use non-invasive ventilation? And amongst the non-invasive ventilation, whether should we use CPAP versus BiPAP? All those controversial questions will remain unanswered during this period. And also one of the interesting questions was, in the resource-poor settings or where the healthcare systems were strained, can we really prevent or shorten the duration of mechanical ventilation with the use of NIV? And just there is significant data is available through some of the systematic review and meta-analysis of some small randomized controlled trials and prospective observational trials around early versus late intubation, which again favors late intubation than early intubation, with a caveat that the data is not very well collected. Most of those trials are prospective observational trials. Now, since the data was in favor of late intubation, people decided to delay intubation. And in the meantime, obviously, these patients were still hypoxic, so needed some sort of oxygen therapy. And that's why the NIV question came into picture. Now, before the Recovery RS trial was published, there were a few studies which were published. One was around the effect of high flow oxygen therapy versus conventional oxygen therapy. It was a randomized controlled trial which was published in December 2021. And this trial basically, again, showed some benefit of using high flow oxygen therapy with regards to decreased number of intubation or decreased length of stay. And then another landmark trial was HE NIVOT trial, where they compared helmet non-invasive ventilation versus high flow oxygen therapy. And with the use of helmet non-invasive ventilation, there was decreased cumulative incidence of intubation. So again, there are a couple of trials which showed the NIV is probably more beneficial than high flow. And the problem with the HNIVOT trial, which was published in JAMA, it was a small single center trial, included only around 109 patients, and studied basically the median respiratory support free days as a primary outcome, which was again not a very good outcome to study. And on the top of that, there was a lot of variability in the international guidelines, including in Australia and New Zealand, where the different societies decided to recommend differently about use of NIV in COVID-19. And also we observed this variability in our local ICUs here in Sydney. So Dr. Chacko, first of all, your quick thoughts on what treatment did you use in second wave with regards to use of NIV versus high flow, and how was your experience?
In fact, we were using both high flow nasal cannula and NIV quite extensively. Obviously, given the numbers that we had, it was not really a viable option to intubate them early as it is described. So as is the practice in most other parts of the country, we were trying out non-invasive support with both high flow nasal cannula and NIV. The way we used high flow nasal cannula was using maximum flows and then titrate their FiO2 down to as low as possible. And NIV, we almost always used with inspiratory pressure support. We hardly used NIV with CPAP alone, as they did in this study. So we have quite extensive experience with the use of non-invasive respiratory support. And I must say that the results were quite satisfying in that we do believe that we could save intubation and ventilation, invasive ventilation in many of these patients now.
Thanks, Dr. Chacko. So again, that highlights, again, the variability between different countries and different ICUs. And it's more of anecdotal experience that people then went with, but actually the hard statistical data is still lacking on this topic. And that's why I think the recovery RS trial is quite interesting to analyze. So may I ask you to walk us through the methods and the results of this trial, please?
Yeah, the question that the investigators asked was, does CPAP or high-flow nasal oxygen compared with conventional oxygen therapy reduce the need for tracheal intubation or mortality within 30 days in COVID-19 related acute hypoxemic respiratory failure? So that's the question they asked. The study design was a 3-group randomized controlled trial, and the trial was conducted across 48 acute care hospitals in the UK during a 1-year period between April 2020 and May 2021. So in effect, the recovery RS trial represented 2 separate trials that compared CPAP and high-flow nasal cannula with a common control group of conventional oxygen therapy. The sites were allowed to randomize patients to CPAP, high-flow nasal cannula, or conventional oxygen on a 1:1:1 basis, or either of CPAP or high-flow nasal cannula against conventional oxygen therapy as a control on a 1:1 basis, depending on availability of the device. Randomization was stratified by hospital site, gender, and age. The study population included adult hospitalized patients with known or suspected COVID-19 and acute hypoxemic respiratory failure. They defined acute hypoxemic respiratory failure as patients who were saturating less than 94% with a FiO2 of 40% or more. And these patients were obviously intended for full support if required, including invasive ventilation as required. In other words, there was no limitation of treatment. They excluded patients in whom immediate intubation was considered required at that point of time. And patients who were only for end-of-life care were not included in this study, as were pregnant women. On the intervention arm, the interventions, as I mentioned, included 3 different modalities of support. Conventional oxygen therapy, which was a control for both high-flow nasal cannula and CPAP, was administered through a standard mask or a nasal cannula. In the CPAP group, they received no positive inspiratory pressure. It was just expiratory pressure alone. The choice of device, setup, and titration of support were based on individual policies or clinician judgment. Intubation was also based on clinician judgment. Crossover was allowed between CPAP or high-flow nasal cannula, and it was considered to be a crossover if the crossover modality lasted for longer than 6 hours. How do they calculate the sample size? They calculated the sample size based on a 15% incidence of the composite primary outcome of intubation or mortality within 30 days of diagnosis of randomization into either of these arms. So assuming a 5% reduction in the composite primary outcome, and for a power of 90%, for a two-sided significance level of 0.05, they calculated a sample size of 1,000 patients in each group. Later on, they amended this sample size to 4,002 because there was considerable uncertainty regarding event rates because it was a new disease at that time. Very little was known about the outcomes. And also the incidence of COVID-19 was changing from time to time. And so they planned to increase the sample size to 4,002. And they also intended to do inverse probability weighting, which is a method that is used to correct for crossover from one modality to the other. Analysis was based on the intervention that patients were randomized to. What were the results of the study? Although they intended a sample size of 4,002, the trial was stopped early due to a decline in COVID patients and lack of continued funding after recruitment of 1,278 patients as against the projected number of 4,002. So 1,278 patients were randomized. 5 of these patients were excluded because of randomization error. So 1,273 were included in the trial, divided into 3 arms: CPAP, high-flow nasal cannula, and oxygen. In the CPAP group, there were 377 patients for the primary outcome analysis, 415 for the high-flow nasal cannula group, and in the oxygen, 356 were included in the comparison with CPAP and 368 in the comparison with high-flow nasal cannula. The mean CPAP level that they used was 9.5 centimeters of water, and the mean flow rates on the high-flow nasal cannula was 50.8 liters per minute. Now let us look at the outcomes. The composite primary outcome was, as I mentioned, a composite of tracheal intubation or mortality within 30 days of randomization. And when they compared CPAP of 5 versus conventional oxygen therapy, the composite outcome occurred in 137 of 377 patients in the CPAP group, 36.3%, compared to 158 out of 356, which is 44.4%. So 36.3 versus 44.4 in the conventional oxygen therapy group. And this difference was statistically significant, favoring the use of CPAP of 5 compared to conventional oxygen therapy. How about high-flow nasal cannula versus conventional therapy in terms of the primary composite outcome? It was 44.3% in the high-flow nasal cannula group versus 45.1%. The difference was not significantly different. So the composite primary outcome was not significantly different with high-flow nasal cannula. It was significantly in favor of CPAP. They also looked at secondary outcomes. The secondary outcomes included the individual components of the primary outcome, namely tracheal intubation within 30 days and mortality within 30 days. And with the use of CPAP of 5, tracheal intubation rates was 33.4 versus 41.3%, again favoring CPAP over conventional oxygen therapy in terms of the requirement for tracheal intubation within the first 30 days. However, mortality within 30 days, even though it was numerically lower with CPAP at 16.7% compared to 19.2% mortality with conventional therapy, this difference was not statistically significant. With the use of high-flow nasal cannula, neither tracheal intubation rates within 30 days or the mortality rate within 30 days were significantly different between high-flow nasal cannula and the conventional oxygen therapy group. They also looked at the rate of admission to intensive care unit. in the sense that these patients were managed in respiratory units out of ICU, and they would be transferred to ICU if the need arose. So admission to intensive care unit was lower in patients treated with CPAP at 55.4% compared to 62.9% with conventional oxygen therapy. The difference was statistically significant. The difference in terms of admission to ICU was not different with the use of high-flow nasal cannula. They also looked at the time to event, time to intubation, and time to mortality. The time to intubation was longer with the use of CPAP compared to conventional oxygen therapy, while there was no difference with high-flow nasal cannula. The time to mortality was not different with the use of either CPAP or high-flow nasal cannula. The length of stay in ICU and length of stay in hospital were not different with either CPAP or high-flow nasal cannula compared to conventional oxygen therapy. As I mentioned before, to allow for crossover, there was quite a few crossovers. From the high-flow nasal cannula, 11.5% of patients crossed over to the CPAP arm, while from the CPAP arm, 15.3% crossed over to the high-flow nasal cannula arm. So to allow for this crossover, to reduce the bias that results from crossover, they performed what I mentioned before as inverse probability weighting analysis to try to account for these crossovers and remove any kind of bias that may go with it. And even after adjustment, the results were not different. They were similar to what I've already described. They looked at a few post-hoc outcomes as well. In the post-hoc outcome, they compared CPAP versus high-flow nasal cannula head-to-head in terms of the composite primary outcome. It favored CPAP. The composite primary outcome occurred in 34.6% with CPAP compared to 44.3% with high-flow nasal cannula, p-value of 0.02 in favor of CPAP. The ICU and hospital mortality was no different between the two groups. The length of stay in ICU and hospital were also not different between the two groups in the post-hoc outcome. Exploratory outcomes included adjusted analysis and inverse probability weighting analysis, as I mentioned, were consistent with the primary analysis and not different from the primary analysis. They looked at subgroups of patients based on age, gender, BMI, race, time to randomization, FiO2 of 60% versus more. And they found that for high-flow nasal cannula, patients who were on FiO2 more than 60% benefited compared to conventional oxygen. So that was a subgroup analysis. Adverse events were more with the use of CPAP and high-flow nasal cannula. In fact, with CPAP, they described 4 serious adverse events possibly linked to the use of CPAP, including surgical emphysema, pneumothorax, pneumomediastinum, and vomiting in a patient which required emergent tracheal intubation. So in effect, this study essentially showed that the composite primary outcome of intubation and mortality within 30 days of randomization were significantly lower with the use of CPAP of 5 compared to conventional oxygen therapy. And with high-flow nasal cannula compared to conventional oxygen therapy, there was no significant difference. So that was the main finding of this study.
Thanks, Dr. Chacko. So again, this study is quite fascinating because this is probably the largest study on this topic where they compared NIV versus conventional oxygen therapy and high flow versus conventional oxygen therapy. Now, one can argue that there was no head-to-head comparison planned as a primary analysis for CPAP versus high flow. But having said that, doing this trial in the middle of the pandemic in a busy respiratory wards outside the ICU was quite a lot of challenge. So I guess kudos to authors for pulling out this trial in the midst of the pandemic. And also important thing to know that is obviously the trial was stopped early due to lack of funding, plus the COVID numbers were going down. And I guess this brings down to the important point in conduct of trials during the pandemic, because you need to really conduct the trial at the peak of the pandemic. There is no point in conducting the trial when the patient's number are subsiding, because obviously that will change the mortality significantly. And I guess this is probably the highlight of the trial, even though the trial did not reach the full recruitment, they did manage to conduct the trial in the peak of the pandemic, which is more important. Also, they did some covariate adjustments, because when you look at this particular outcome of intubation or mortality in COVID-19, that had multiple factors which could have affected that independently, such as age, sex, morbid obesity, ethnicity, FiO2, respiratory rate, and then treatment phases. Because before July 2020, there was no steroids. Then between July 2020 to January 2021, there was dexamethasone was introduced. And after January 2021, the immunomodulator or immunotherapy or treatments like tocilizumab were introduced. So authors did consider all these different factors which could have impacted the mortality and intubation. And again, because of this covariate adjusted hazard ratio analysis, we get a bit more clearer picture of impact of intervention directly on those two primary outcomes. Now, one can argue that obviously the composite endpoint is a challenge in any study. When you're trying to see the impact on mortality, at the same time, you're trying to see the impact on intubation, it's probably not the ideal way to do any study. Having said that, doing the study in NIV, one can argue that this is a natural progression of the disease, where when the respiratory failure worsens, patient go from conventional oxygen to either NIV or high flow, and then go to intubation and then death. So I guess what authors argued in terms of collecting this composite primary outcome is it's almost like a natural progression of the disease. So, and doing the study with sole mortality was probably not the best way to study any impact of NIV on respiratory failure. Another limiting factor for this study was the crossover. And I guess in CPAP group, there are 15.3% patients crossed over to high flow. Similarly, from conventional oxygen therapy, roughly around 23.6% patients crossed over to either CPAP or high flow, and around 11.5% patients from high flow oxygen therapy crossed over to CPAP. Now, one can argue that whenever there is a crossover occurs in the study, that obviously dilutes the effect, and that leads to underpowering of the study, and the impact is not as initially planned. Having said that, when you look at the crossover actually happened in the both directions. And one can argue that that has probably nullified the effect of crossover. And that's why the results of the study are still reasonably valid. Another interesting finding from this study was when you look at the impact of the intervention on individual primary outcome, there was no difference in the mortality, but definitely the intubation rates reduced with the use of CPAP. And that has led to decrease in the composite primary outcome, because the impact on the intubation was more significant than the impact on mortality alone. And that probably again raises the question, because the impact on intubation was so significant, whether this intervention leads to decrease in mortality. And the answer to that, we don't know. Also, another interesting point to discuss is about the external validity of the study. The internal validity of the study is pretty robust. It's very well conducted. It's a randomized controlled trial. Unfortunately, obviously, you can't blind this study, but then there was allocation concealment was performed, and it was done. The loss to follow-up was very minimal. The primary outcome data was available in almost 99% of the patients. So all the boxes for internal validity are ticked. Having said that, when you look at external validity, now one can argue that NHS settings or UK settings are probably similar to any other first world country. Having said that, this study was conducted predominantly in the respiratory ward settings, and that probably has an impact, because performing the study in intensive care unit compared to applying the same intervention in the ward setting is quite different, because the nursing ratios will be different. The amount of care provided to these patients will be different. Whether this study translates to outcome of patients in intensive care unit is unknown. Having said that, this study has definitely given us some signal with regards to whether this intervention works in sick cohort of patients with COVID-19. And one more finding from the table, that when I looked at the FiO2 requirements, that patient in the wards with almost up to 90% FiO2, which is a bit hard to accept sometimes, because imagine the patient is sitting on the respiratory wards with 90% or 60 or 70, 80% FiO2 with CPAP, with limited nursing ratios can be quite challenging. And I guess the decision to intubate, one can argue, was quite delayed in these patients. And we don't know whether these patients, if they would have been intubated early, would have had different outcomes. But again, one can argue that this was obviously a randomized controlled trial, so that all those effects will be probably nullified. Now, as you said, they did provide inverse probability weighting analysis, which minimized the effect of crossover, and there was no impact due to crossover. And what this study highlights to me is also you need to be very careful about the side effects of the intervention, because it can be easy to just put on CPAP and 8 centimeter of water, what happened in this study. But as you're increasing the pressures, obviously your volume are going to increase, and then these patients will be at risk of volume trauma. And if there is no adequate monitoring available for these patients are really at risk of significant barotrauma or pressure injuries. Listen, what happened in the study, like pneumomediastinum and pneumothoraces. I think that's the key risk of this intervention. So one thing, yes, this intervention can delay the intubations, and also can delay the ICU admission, but also we need to be mindful that this intervention can also be harmful. And I think that's the kind of key observations from my side. What's your take on this trial, Dr. Jacko?
Yeah, it was a very well conducted trial under testing circumstances of the pandemic. They did very well indeed to go through the study, even though the sample size was much lower than what they had initially projected. And they came up with this important finding that CPAP may be effective in reducing the requirement for intubation at 30 days. So that's a very significant finding. And I think particularly considering the fact that people were a little bit hesitant to use non-invasive ventilation in acute hypoxemic respiratory failure of any etiology. So this study offers some support to the fact that you could perhaps use non-invasive modalities of support to begin with until the stage reaches wherein your patient may require intubation, and that might actually result in improved outcomes. So to me, it lends additional support for non-invasive respiratory support in general among patients with acute respiratory failure. So the other question, of course, is that they used CPAP alone without the use of any inspiratory pressure support, which is perhaps not a very common practice in many parts of the world. For instance, in our unit, we very rarely use CPAP alone, except perhaps occasionally in patients with cardiogenic pulmonary edema. So we don't usually use CPAP alone. So that is another question that, again, needs to be answered, whether the addition of inspiratory pressure support would further augment the effect of non-invasive ventilatory support. As you mentioned, they could not reach the sample size. So although the mortality was lower, it was not statistically significantly different in the CPAP group compared to the conventional oxygen therapy group. This could be, I think, largely explained based on the reduced sample size, because the mortality in this study was roughly 20% or so among all patients. And if you consider that it would reduce the mortality by 5%, you need a sample size of at least 2,500 patients, which is initially what they plan to do. So just lack of sample size could explain perhaps the absence of a mortality benefit with the use of CPAP. The other thing that maybe bemuses me a little bit is the seemingly lack of effect of high-flow nasal cannula, which is a little hard to explain for me, because there are several studies which have used high-flow nasal cannula effectively in acute hypoxemic respiratory failure. The Florali study is a classic example. So why would it be that you couldn't come up with a similar kind of efficacy in patients with COVID pneumonia? So that question remains unanswered. The next question would be, instead of confining yourself to a single modality of support like CPAP or high flow, would a combination of these therapies, depending on the circumstances, would that make a difference? For instance, in our practice, we have actually used high flow nasal cannula initially in many of these patients. And if they don't seem to be doing okay, and if they look like they need a little more support, we very often switch to NIV with inspiratory pressure support. So that's another maybe a real world practice which perhaps needs to be tested out as well in patients with acute hypoxemic respiratory failure. But overall, I think this study really helps us understand the efficacy of non-invasive respiratory support in patients with acute hypoxemic respiratory failure. And it further bolsters the consideration that non-invasive modalities of support may indeed be beneficial in patients with acute hypoxemic respiratory failure, including viral pneumonias and maybe ARDS to other reasons as well.
That's correct. And I guess with regards to use of high flow and lack of effectiveness in this particular study is hard to explain. But I guess the question is sometimes you cannot regulate the amount of pressure generated with the high flow, especially when the patient is breathing at a rate of 30, 40. And I think these patients definitely needed extra PEEP to improve their oxygen levels. And I guess probably high flow was not effective in this setting, mainly because of their higher respiratory rates and unable to deliver the amount of pressures that these patients needed. And that's probably the only explanation I could personally think about. But I guess looking at the study, overall evidence, and the robustness of the trial, I guess I'm convinced that yes, NIV is indicated in patients with COVID-19. That is now very clear. Having said that, I still don't believe that it should be used as a blanket treatment to every single patient in COVID-19. I guess that's why we need to go back to this individualized goals and personalized approach of management with regards to use of NIV. And I just wonder, often we traditionally treat hypoxemic respiratory failure in escalation strategy, and we put a high flow first, then NIV, and then intubation. And wonder whether there might be a role to actually start NIV first and then de-escalate to high flow. And obviously that's the answer which we don't know. And also, I guess in terms of whether to choose NIV or not, the clinical trajectory of the patient and the disease progression is more important than adherent to any fixed dogmatic practice that just use CPAP or BiPAP by default of 10 centimeter of water. So I think that shouldn't be the practice. And I think these patients will definitely benefit from close monitoring of their vital parameters, and including some of the ventilatory parameters such as respiratory rate, tidal volume, CO2 exchange, and other things. And once you decide to put any patient on NIV, I guess reevaluating the patient's progress every 12 to 24 hours and see whether really the NIV is benefiting or not. And I guess if there is no benefit after 24 to 48 hours, that's where you need to really start thinking whether these patients need intubation. Because prolonging the NIV and then dragging these patients through significant hypoxemic respiratory failure for a few days and then deciding to intubate might not be the best approach for these patients. Any final thoughts, Dr. Checker?
I totally agree with you on that. Whenever you use a non-invasive modality of support, be it NIV or high-flow nasal cannula, very important to monitor them closely by the bedside to follow the trajectory, and whatever interventions you follow depends entirely on the way they respond to be it NIV or high-flow nasal cannula. And although you cannot set fixed time frames and it is largely based on clinical judgment, you shouldn't drag it for too long. There is an ever-increasing body of evidence that supports the fact that if you delay intubation too much, that'll obviously result in poor outcomes. So that's something we got to be wary about and intubate them at the appropriate time and not let things drag on if there is no signs of clinical improvement.
Yeah, absolutely. And I think that's why the personalized approach of management with NIV in COVID-19 is probably more rational way to go forward. And I guess understandably, it can be challenging in the setting of pandemic where the healthcare system is overwhelmed. Having said that, we still need to be very mindful about the hazards of any intervention that we apply in our patients. So thanks, Dr. Checker. That's the end of our today's podcast. So we'll be back in week's time with another interesting controversy. So till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening. See you next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.